button. So without further ado, I'd like to introduce our first speaker, and that's Sarah Clifford from Menzies School of Health Research, where she is a postdoctoral researcher, and her work focuses on the relationship between alcohol use and harms and how policies can impact these outcomes. And she's currently undertaking a fellowship focused on commercial determinants of alcohol use and harms in the NT. And in fact, I believe her almost there, PhD, or completed but yet to be signed off, was in fact on the effects on domestic, family and sexual violence on the banned drinker register, minimum unit price, and police auxiliary liquor inspectors, or PALIs as we like to call them. Okay, Sarah, over to you.
Thanks very much, Tanya. Just let my slides pop up. Great. So today I'm going to be focusing on the measuring component of the webinar. Before I begin, I'd like to acknowledge that I'm joining this meeting from Larrakia country and pay my respects to elders past and present. So the area of land that we now call the Northern Territory has been populated for at least 60,000 years, comprised of many distinct Aboriginal nations. Although Australia's colonisation by Britain began in 1788, it wasn't until the 1860s that one of a British settlement was maintained. And since then, the capital city has been destroyed almost twice. Even now, the NT is much less populated than the rest of the country. Now, there is a lot of aspects to the NT, but particularly remote NT, that can seem pretty foreign. Lots of places have no sealed road access, which means that at certain times of year, places can be cut off. This can interfere with things like food security. Remote places are more vulnerable to power and communication loss. Access to things like healthcare and the legal system can be more challenging. There are also lots of Aboriginal languages spoken throughout the NT, and for many people, English might be a third or a fourth language. So alcohol was introduced as part of colonisation, often in a transactional sense, and it's something that many Aboriginal people see as causing harm. Aboriginal people were granted the right to drink in 1964. Since then, there has been a long history of grassroots initiatives to limit alcohol access. So in the first NT Liquor Act, there was a provision to allow communities to make specific requests, and then they could have those requests legislated. On the Gove Peninsula, where I usually live, I'm in Darwin at the moment, but I usually live in Nhulunbuy. This looks like a liquor permit scheme. This is where everyone starts from a baseline of not being able to purchase takeaway alcohol, and then you apply for that privilege. So when restrictions are introduced, of course, people want to know if they work. The thing about these localised community level restrictions is that they typically impact really small populations. And this becomes a problem for understanding their impact. So even in places where there might be higher rates of alcohol-related harm, small populations can mean the counts of the outcome are still likely to be very low. That can mean you don't have power for statistical analysis, or if you can, maybe you can run some stats, it's not a meaningful resolution. Maybe you can only look at, say, yearly outcomes instead of monthly or quarterly. Depending on how you need to collapse that data, again, like monthly, quarterly, yearly, things like seasonality, which have a really big impact in the NT, can be hard to account for. Aboriginal communities often have highly mobile populations, and so small changes might have a bigger proportional impact. The data that's used to assess changes in alcohol-related harm is often administrative data, and that's influenced by the administrative service provision. So if there's staffing gaps in a clinic, or if maybe healthcare is provided on a drive-in, drive-out service and there's floods or roads are cut off, you're going to see changes in the admin data that might not reflect actual changes in harm. Even when there's a lot of effort to unpick factors that might be influencing different spikes or troughs in the data, it can be really muddy. So, as I mentioned earlier, I live in Nhulunbuy. Recently, there was a lot of unrest on the local grand final weekend. So someone might look at the police stats from that weekend and say, and also look at what was happening in the community and say, okay, well, that's because of the grand final, that must have had some impact. In fact, there was actually a domestic violence murder that occurred in Darwin, and both the victim and the perpetrator had family connections in the region. And so something that seemed really, really unconnected that happened, over 1,000 kilometres away, had impact in a very, very small place, very far away from the actual incident. that picture I just painted can seem a little bit dire in terms of like, how can we understand grassroots restrictions? But there are a lot of really excellent evaluations that have managed to work around these challenges. So Curtin Springs is a really old example, but it's one of my favorite ones because they really walk you through what was available to them and exactly how they made their decisions in terms of what got included, what they couldn't use, why couldn't they use it. So because the evaluation was an evaluation of an agreement that had taken almost 10 years of negotiation, there was legal disputes, it was a really important one to get right. Some of the challenges that they contended with were there was different definitions of what an alcohol-related contact was in different health services. So some of the communities that were affected by this change were in the NT, and Curtin Springs is quite close to the border. And so some of the communities that were affected were in SA. Those health systems are different. The clinic definitions were different. They also thought, okay, well, we'll look at like police activities. And even though there were Aboriginal community police officers in Mutijulu, one of the communities, Yulara, the main police station, who kind of kept all the records and were the more formalised police station, only attended Mutijulu when there was a serious incident and when arrests were made. So it wasn't like a complete capture of harms that were going on. However, the evaluation uses interviews and as much administrative data as they could, and also some documentary material, and kind of paints this really, really rich story and walks you through what they were able to find out in terms of changes. However, even when these pretty comprehensive evaluations are undertaken, because of small populations, often an inability to run statistical analysis, they often don't meet like our hierarchy of evidence. So Hines and colleagues did a systematic review which looked at the association between alcohol restriction policies and rates of alcohol-related harm in remote Australian Aboriginal and Torres Strait Islander communities. And they concluded that they couldn't conclude anything because of the types of studies that are done in these settings. Now, alongside grassroots restrictions, there's also been many alcohol policies and restrictions introduced in both by the Northern Territory and by the federal government. In many cases, these restrictions are innovative, they don't exist in other places. And because alcohol is highly politicised and certain policies are aligned with certain political parties, there's often a lot of pressure to understand how what effects these policies are having. So many of the larger alcohol policy changes do get evaluated. However, even at the NT level, there can still be challenges. So the NT is still really small, even when we're including the whole territory. It's only 1% of the Australian population. And because alcohol is so politicised, we often get these policy windows where multiple policy changes get made quite quickly. Sometimes there are regional differences in terms of the application of policies, particularly where NT policies might intersect with existing regional ones or those other localised grassroots restrictions. Many NT policies also target certain groups or cohorts. Now, of course, there's a lot of time and effort that goes into designing studies that can account for all these factors. There are ways to account for confounders. You can analyse at a regional level instead of an NT level. You can control for multiple interventions. You can do data linkage to see changes for policies that target individuals. So what's the individual level of change? But even then, there's still challenges with measuring different types of alcohol-related harms. So Tanya mentioned earlier, my PhD looked at domestic, family and sexual violence, which is often a very hidden harm. It's not captured particularly well by police or hospitals. They only capture that real tip of the iceberg. And of course, this challenge exists for all alcohol policy evaluations. So this is not an NT specific problem, but it is really important to consider when we think about how evidence is able to be made.
2 minutes, Sarah.
Now, earlier in the slides, I mentioned the phrase, we're different up here, which any NT members of the audience might have recognised as slightly tongue-in-cheek. It is true, of course. I talked earlier about the ways that the NT is different to lots of other parts of Australia. But it is often a phrase that's used to justify policies and practices that are not supported by evidence. The vibe of the phrase can sometimes be it might not work, but if it doesn't, don't blame us. There's so many conflicting factors going on. And in some cases, it is really important to develop policies for context. But if we stay too far down that end of the scale, we can miss integrating good evidence from other places. It can also mean that even when policies have evidence from other places, and I know Nick is going to talk about MUP in quite a bit of detail in a moment, we can ignore the evidence from other places, saying that our context is just too different. So I've just spent the last 10 minutes telling you how challenging it is to generate evidence on alcohol policies in the NT. But there is also a question of where evidence is helpful. In terms of grassroots community approaches, making sure that there is community buy-in to an approach is really, really important. So I know Nicole Hewitt's talked about this. I know Peter Dabbs has written about this. But even when the same policies are implemented, you can see different outcomes based on whether there was community ownership of the policies or the restrictions. And that's why it's really important that we recognise the legacy of colonisation and of approaches being used on people instead of requested by people. Now, lots of people living in remote Aboriginal communities are still interested in what works elsewhere, but they also want it to be meaningful for them and for their families. In terms of NT level policy, however, it is really important that we don't end up too far down the we're different up here mindset. Using evidence from other places means that we're more likely to get alcohol policies that result in meaningful change. Of course, it's not to say there should never be room for innovation. The NT pretty famously had a really, really innovative policy in the 90s and had a huge impact of harms. That was completely kind of NT specific. It was very much locally generated. So there is space for innovation, but we should definitely be leaning on evidence from other places where we can. Thank you.
Thank you, Sarah. That was terrific. And I think you're talking about the Living with Alcohol program there in the 1990s. Yeah, what a great program that was. So if you have questions for Sarah, please hold on to them and we'll take them in the Q&A box, which you can find option at the top later on towards the end of the presentations. Right, so next up we have Stephanie Holmes, and Stephanie Holmes is Executive Officer at the Association of Alcohol and Other Drugs Agencies, NT, otherwise known as ADDNT, I think. And the peak body for frontline drug and alcohol services in the NT. And in her role, Stephanie's leadership is working with policymakers, communities and frontline services to improve access and delivery of drug care through government and community-controlled services. Over to you, Stephanie.
Many thanks. Hi, everyone, and welcome today. I'm going to be talking around the challenges of regulating, reducing and measuring alcohol-related harm in the Northern Territory. In the Northern Territory, we have high rates of alcohol misuse and harms, and these harms increase our health risks. So I'm going to talk around the high levels of alcohol consumption are linked to a wide range of health issues, including liver disease, increased risk of cancers. We know, FASD and other things. And high rates of alcohol use and harms is also impacting on our social and community impacts. So excessive alcohol use contributes to family and domestic violence, child neglect and community safety concerns, leading to a broader social and economic costs. And we also know with the high rates of alcohol use and harms that we have, that it's a burden on health services. So alcohol-related harms place significant pressure on our healthcare system and systems, including hospital presentations, emergency, service responses, and particularly in our regions with higher alcohol use rates. We also understand there's an intersection of alcohol with other social harms, and alcohol and domestic and family violence, and the intersection there with alcohol being a significant domestic violence incidents, often escalating the severity of abuse and contributing to cycles of trauma and harm within our families. Alcohol and crime. There's a high level of alcohol consumption are frequently linked to increased rates of violent crime, antisocial behaviours, public health disturbances, along with community safety. Alcohol and mental health intersection. We understand that alcohol misuse can exacerbate mental health conditions like depression and anxiety, often leading to a higher risk of suicide, self-harm, and substance dependency, compounding overall social and individual harm. The impact on our communities. We understand that there's a significant impact on our communities, and this puts a lot of strain on health and emergency services. Communities with high alcohol use often face increased demand on hospitals, emergency rooms, presentations, and also increase in law enforcement. With this increase, there's also a lot of diversion of resources from other critical needs. Part of the impacts on our communities is also around the erosion of social cohesion. Alcohol-related harms such as violence, neglect, and antisocial behaviours undermine our communities' well-being, fostering environments of insecurity and often disconnection. And the economic costs and the financial burden of alcohol-related harm, including healthcare expenses, legal costs, and lost productivity, can stifle community development and drain public resources. In the Northern Territory, we have a unique demographic, making AOD service delivery often challenging. We have large Indigenous populations. The Northern Territory has the highest proportion of Indigenous Australians, around 30%, who often face disproportionate challenges related to alcohol use, health disparities, and access to services. Our remote and dispersed communities, many Northern Territory residents live in very remote or remote locations, making access to health, education, and social services difficult, contributing to heightened vulnerability to alcohol-related harms. We also in the Northern Territory have a young transient nature. The Northern Territory has a younger medium age than any other state or territory, leading to unique social and economic challenges, including higher rates of risky behaviours like alcohol misuse. The impact on the health system and the AOD treatment capacity is significantly under-resourced, and these are based on national figures. Limited access to services throughout the Northern Territory's vast and geographically remote communities limit access to drug and alcohol treatment services, particularly in rural and remote Indigenous communities. Our services are often overstretched, and the resources are as well. The Northern Territory's health system is often overstretched, with hospitals and clinics managing a high burden of alcohol-related harms. These place significant strain already on limited staff and infrastructure. Our workforce shortages across the sector and the treatment sector in the Northern Territory faces significant shortages, limiting the capacity for timely and effective interventions, especially in remote and underserved regions. The social determinants of alcohol harms. We understand that poverty and unemployment, socioeconomic disadvantage, including high rates of poverty and unemployment, contribute to increased AOD use, as individuals may turn to substances as a coping mechanism for stress and a lack of opportunity. We also understand in our communities the housing instability, so homelessness or unstable housing situations often exacerbate AOD use, as individuals facing insecure living conditions may have limited access to support services and experienced increased social isolation. We also know that education and early life experiences impact the social determinants. Low levels of education and adverse childhood experiences such as trauma or exposure to substance use are key predictors of future AOD issues, creating a further exacerbating intergenerational cycles of harm. Thank you.
Oh, that was very well kept to time. Thank you, Stephanie. Terrific. Okay, that's given us a lot to think on as well. I think we'll now throw to our final speaker, Nick Taylor, Dr. Nick Taylor, and he is an alcohol policy researcher at the National Drug Research Institute. And much of his work, in fact, has been focused on the Northern Territory's alcohol floor price, or minimum unit price if you prefer. And I think he'll be speaking around that topic today. Over to you, Nick.
I sure will be. One moment, I just need to get my PowerPoint up. And here we go. Okay, so today I'm going to be talking about alcohol affordability and some of the challenges that come up when measuring the impact of policies that affect alcohol affordability on alcohol-related harm and consumption, with the minimum unit price in the Northern Territory as sort of our context. I'd first like to acknowledge the traditional custodians of all the lands that we're meeting today and pay my respects to their elders past and present. So let's get right into it. The minimum unit price. It's been around since the end of 2018. It's an intervention that was designed more or less to target the consumption of cask wine, which could be sold at about 60 cents per standard drink. The minimum unit price set a floor value or a retail sales minimum of $1.30 per standard drink. And the impact of the policy was pretty remarkable. It halved the consumption of cask wine. We saw declines in alcohol-related assault, some declines across the territory, but specifically in Darwin, a 14% decline in assaults that could be attributed directly to the policy. There's also been some really good evidence to suggest there's been a decline in alcohol-related health service usage, so emergency department, ambulance, and some really good evidence to suggest that there's been really no financial impact on either drinkers, moderate drinkers, rather than heavier drinkers, or the alcohol industry as a whole. And it would be remiss of me not to mention that we've seen some really promising trends in alcohol-related deaths in the Northern Territory since the policy came into place. So how does this policy work? Essentially, it increases the price of the cheapest alcohol by a little bit. That doesn't matter so much for like a one-off purchase or, two purchases or whatever, but over time and over many purchases, the price increase will be quite substantial. And so you tend to see, or you'd expect to see a decline in habitual alcohol consumption, particularly heavy consumption. Now, it's important to note here that alcohol consumption in Australia more widely is very top heavy in that 10% of Australia's heaviest alcohol consumers, they account for 50% of the alcohol consumed in Australia. So for this sort of pricing policy to be really effective, it needs to at least cover that drinking. So how do we estimate coverage of the minimum unit price? There are a few different ways that alcohol researchers have done it previously, namely surveys using wholesaler data or online price monitoring, otherwise known as data scraping. Surveys is just when you go out and ask people or you ring them up or maybe even email them. On this slide, there's a study pictured that used a survey which showed that about 40% of the market would be covered by a $1.30 minimum unit price, which is good. That would be most of the drinking done by Australia's heaviest consumers, when you think of it with that frame. Then you have wholesaler data, which the Northern Territory regularly collects and publishes every quarter. It's a really accurate representation of all the alcohol that's being consumed in the Northern Territory, but you don't get any information about the price that it's being sold at, and you can't really look at individual drinkers. So it's good for measuring the impact of a policy, but not really good for predicting or knowing how many people have been affected, really. Then you have online price monitoring. So people have used this to see exactly how many products are sold under a particular price point. For example, how many are sold under $1.30. It's really good for that. It's really good for a precise knowledge of the price point that alcohol is available at. But you don't know how much alcohol is sold at that price point. So it can really distort the market, as we'll see in the upcoming slides. Then there's retail sales data, which is the gold standard. It's sort of the holy grail in this space. But it's not really available to most public health researchers. In fact, in the Northern Territory, it only came out because of the 3-year evaluation, which made use of retail sales data. And I've got a little timeline here, which shows you from the conception in 2017 of the policy to 2021, there was no retail sales data available to help inform the intervention. Then only in the 3-year evaluation in 2022, and notably the end of 2022, did that information become public. And even then, it's only in 2024 that public health researchers have been able to utilize that. So what does this data look like? It looks, this is my little recreation of it here with cask wine, bottled wine, beer, and cider. It just shows you the number of standard drinks that are sold at each price point. So right at the end there, it shows you how much standard drinks were sold at 60 cents and so on across that graph. Oh, sorry, I did want to note, and it's available by region and liquor type as well. So you can see how much alcohol was sold in Darwin, Alice Springs, or cask wine, beer, that sort of thing. And it's been really good. It's been really useful data. We've been able to determine the actual coverage of the minimum unit price as a result, which is about 19%, which is interesting because it's not even half of what Australia's heaviest consumers drink. So it allows us to predict what would have been an appropriate minimum unit price if we wanted to cover all of that drinking. It's also given us some other unique insights. So it's allowed us to see how drinking has shifted as a result of the policy, and it allows us to estimate the impact on the alcohol industry. So it's a bit hard to glean from these graphs. I'm sorry about that, but essentially the alcohol industry more or less broke even after the policy. So how does retail sales data look compared to the other methods that public health researchers used? This is just a quick comparison to price monitoring data, web scraping data off like the most common online bottle shops. And as you can see, online data scraping, price monitoring data really underestimates the poor or the cheaper end of the market. And then when you make the comparison to survey data, so retail sales versus survey data tends to overemphasize the lower end of the market. So really, there's no really reliable way to recreate this really necessary data. Which brings us to, well, where is this data? Why don't we have it all the time? It's because it was provided by the alcohol industry for the 3-year evaluation. Before the evaluation in 2020, the custodians of this data, Retail Drinks Australia, claimed to have a report that showed that a minimum unit price had actually increased alcohol consumption, despite what all the researchers had said. They said they'd make this report public. They never did. But that information was allowed into the media and into public discussion, and it informed debate. Politicians could be influenced by that sort of thing. Journalists certainly were. And eventually it was just shown to be false. That the retail sales data that was likely used in that report was replicated in the, used again in the 3-year evaluation. And that's just not what it was showed at all. And so this is another timeline where I really highlight that middle period where the data was available to someone who was misusing it, was available to the industry to misinform the public. And even now, the data we have is a one-off time point. We're not getting any more, and yet we know how necessary and vital it is. It's ironic in a way. 2 minutes, that's all good. It's ironic in a way because the Northern Territory nearly legislated mandatory retail sales data collection in 2019. Unfortunately, due to a combination of backlash from the alcohol industry and some misunderstandings about the new policy versus the old policy that wasn't really utilized, it was taken out. Essentially, though, if this had been kept in the bill, we'd have the data that I'm talking about today. It's not that unreasonable to assume that maybe we should move towards mandatory retail sales data collection. This is clearly a unique data source that is vital to predicting how these sort of policies, or modeling these policies to have the impact, an appropriate impact, or an impact that we expect. It's clearly not a burden to alcohol retailers to collect this. They already do. And further than that, they've misused it. And I also don't think it's unreasonable that alcohol retailers, who are essentially the source of alcohol-related harm, have a role, or an obligated role, in preventing the harm that comes from the product that they profit from. Which brings us to the removal of the minimum unit price. So I just wanted to say that without holding anything back, removing the minimum unit price goes against all available evidence. There's absolutely no reason to bring back cheap alcohol. And it's likely being axed because of the misinformation that we've seen over the last 6 years. However, if we are going to remove the policy, then we should at least implement some really innovative, bad at pronouncing that word. We should introduce something to be able to measure the impact. We should be having better monitoring of these alcohol-related harms, alcohol consumption, alcohol purchases introduced, I guess, to make up for it. And sorry, I know I'm hitting my time. Here are some myths that you might have heard about the minimum unit price. I'll just read out the ones that are wrong, which is drinkers have switched to spirits. Nobody's shown that. Nobody's measured that accurately. Cask wine is safer than spirits consumption. That's just not true. It's all about the amount of ethanol you consume, and cask wine's cheaper, so you consume more ethanol. And also I've seen in some media reports that an evaluation found that the minimum unit price should be removed. There have been 2 evaluations of the minimum unit price. They both recommended that it stay. Thank you very much.
Thank you, Nick.